Class, this is a tough topic to talk about, and so if you struggle throughout this lecture, please feel free to stop the recording, take a break, but we do need to talk about miscarriage and intrauterine fetal demise in pregnancy. This is just the better way to discuss this so that everybody feels comfortable or can handle what's we're discussing on their own. But please feel free to reach out to me if you are struggling with this lecture. Early pregnancy loss is in the medical field known as spontaneous abortion. There are other acronyms for it as well, but we're going to talk about each one. In the non-medical field, it's called miscarriage, or loss of pregnancy before the fetus is able to survive outside the uterus on its own. Now, even after 20 weeks, some people still define that as miscarriage when it would be intrauterine fetal demise in the medical field. And so it's important to know how many weeks the miscarriage happened to see what we would term it in obstetrics. Risk factors are advancing maternal age. That could be related to chromosomal anomalies as the woman ages. History of previous pregnancy loss. Smoking can increase our risk for miscarriage. Alcohol, substance abuse, increasing gravidity. So the more pregnancies you have, the more risk you are for miscarriage. Uterine defects and tumors, active infections, intimate partner violence, and chronic health factors. The cause can be fetal reasons, chromosomal anomalies, it could be maternal reasons, and it could be environmental. And sometimes we just really don't know what the cause was for that specific miscarriage. Terming it early pregnancy loss is before 12 weeks gestation. It's usually a fetal related cause, and then late is defined as between 12 and 20 weeks, usually a maternal issue there. And then again, after 20 weeks, it will be called intrauterine fetal demise, or IUFD, which is also known as a stillbirth once it's born. Signs and symptoms of early pregnancy loss is cramping, spotting or frank bleeding, abdominal and suprapubic pain, which may radiate to the lower back, to the buttocks, to the perineum, can cause fever and chills. Laboratory studies, we're going to monitor the HCG level to see if it's decreasing, a CBC, blood typing, blood cross-matching, and coagulation studies, a UA, and transvaginal ultrasound to confirm. These are the different types. In this first image here, we can see that it's a threatened miscarriage or spontaneous abortion. This would be if we can see fetal cardiac activity, but we're having bleeding, vaginal bleeding. In this instance, the cervical os is still pretty closed, but we're bleeding through the cervical os, and we do have cardiac activity. An inevitable abortion would be lots of bleeding. The cervix is starting to open. We could have cardiac activity, or we could have no cardiac activity in this one. An incomplete abortion would be that we have lots of bleeding, the cervical os has opened, no cardiac activity, but there's still tissue from that pregnancy left behind. We would have to do a D&C, or dilation and curettage, to remove those products of pregnancy left behind. A complete spontaneous abortion means that the whole pregnancy has been expelled from the uterus with bleeding and our cervical os is returned to normal. No cardiac activity is present. There's no products of conception. And then a missed abortion would be no cardiac activity. There's no bleeding. We just go in for ultrasound and we don't see a heartbeat anymore. We would kind of wait and see what happens with that one, see if the body will expel it on its own, or we might have to go in for a D&C to remove those products of conception. Treatment depends on the type. No specific treatment can prevent the loss. There's nothing we can do to stop it. We often wait and see if the body will expel it. If not, and encourage rest and pelvic rest. If not, we'll give medication. We can give a large dose of misoprostol or Cytotec, usually 800 milligrams to 1,000 milligrams, all at once orally, and see if the body will expel it with that. Or then we'll go back for surgery for a D&C, dilation and curettage, to remove those products of conception. For nursing care, we're going to provide appropriate assessments, monitor bleeding, and then document everything that's happening. We're going to immediately report any concerns, administer prescribed medications, give appropriate teaching and communication, provide support, offer grief counseling. They've just lost a child, whether that child was full term or not, it doesn't matter. And so grief counseling is super important, and then support groups as well. If the baby is developed enough to see the fetus, we'll allow the parents to view the fetus if they would like, especially when we're in the later weeks of pregnancy. We'll allow them to hold the baby and spend time after it's born or expelled. Cervical insufficiency could be a reason for an early pregnancy loss or a late pregnancy loss. I guess mid-pregnancy loss. It's formally known as incompetent cervix. So the cervix just dilates by itself, but it's called cervical insufficiency now. The definition is painless. They don't get cramps or contractions. Painless cervical dilation with bulging of the fetal membranes, and sometimes the fetal parts will go through the external os. The leading cause it's the leading cause of recurring mid-pregnancy loss. We really don't know what causes it to happen. Again, there's nothing we can do about it if it's the first time this is happening. Risk factors are congenital defects and then history of trauma. If we've had this happen before, our treatment in future pregnancies is going to be a cervical cerclage. Cervical cerclage is where the provider will take a suture and tie that cervix closed so that it doesn't open on its own, hopefully. Once we get to full term, that cerclage, the sutures will be removed so that we can labor. This is gestational trophoblastic disease. This is also known as molar pregnancy. It's a benign, rapid growth of fetal cells, but doesn't develop into a fetus. It's usually placental cells, and they just grow very, very quickly. This person that develops this thought that they were pregnant with a fetus, and so this is also a big loss for them. This can develop into gestational trophoblastic neoplasia, which is malignancy of the uterine lining in about 1 in 5 patients. You can have a partial or complete molar pregnancy. Like I said, it's chromosomal duplication, usually of the placenta, but it can have fetal tissue in it. It can have teeth, it can have hair, it can have bones, but usually it's tissue. Approximately 20% of patients who experience a complete molar pregnancy develop that cancer of the uterine lining within 6 months to a year after a molar pregnancy. So we tell them, please don't try to get pregnant for a year after this happens. We're going to monitor them very closely to make sure that their HCG level decreases and that they're not developing gestational trophoblastic neoplasia. Clinical manifestations, it can be found on ultrasound before symptoms begin. The most common presenting sign is vaginal bleeding. The HCG level is usually higher than expected. It can develop hyperemesis gravidarum, where we have severe nausea and vomiting in pregnancy. Transvaginal ultrasound reveals intrauterine mass, but no fetus. If undetected until the second trimester, the uterus will grow. And so if it's undetected until the second trimester, if we have late prenatal care, we can have dark to bright red vaginal bleeding and pelvic pain, and then passage of grape-like vesicles, tissues coming through. Uterus would be larger than expected, no fetal heart tones, no fetal part seen. We can have preeclampsia develop and hyperthyroidism. Treatment, we give medication to expel that tissue. IV fluids, we need to monitor for hemorrhaging, monitor blood loss. We might have to do a D&C. We can give anti-D immunoglobulin if necessary. Again, they're going to continually follow up for 1 year to monitor for cancer and avoid pregnancy for at least 6 months to 1 year. 1 year is best. Nursing care, we're going to monitor them close, provide prescribed medications, review laboratory results, do thorough observation of respiratory status, promptly report any concerns, offer emotional grief support. This is a loss to them, just like a miscarriage, and then refer to counseling or support groups. Intrauterine fetal demise is death of a fetus in utero at 20 weeks gestation or greater, or a weight of 500 grams or more in the fetus. Not the same as fetal death from early pregnancy loss. Causes can be fetal, placental, or maternal unknown. The most common is placental abruption, so the placenta has somehow separated from the uterine wall. Clinical manifestations and diagnosis, the patient presents when they can't detect fetal movement, so babies decreased fetal movement or no fetal movement, and then we can't find the heart rate, and then we confirm by ultrasound to be sure that there is no heart rate. Treatment, we need to induce labor. These mothers have to birth just as they would a live baby. Our nursing care is similar to a patient having their labor induced. We will provide labor support, heavy emotional care, offer to call the pastor or spiritual leader. Pastors will come in and do a baptism after birth as well, if desired by the patient. We'll collect mementos. We'll do feet prints, hand prints. We'll do pictures of the babies after birth and save those pictures. Sometimes the parents won't want to see those pictures, but then later on, years later, they'll request those pictures. And so we hold on to those pictures for forever, and in case they do change their mind on the pictures. This is just an image. I was at a conference a while ago, and they make a lot of different mementos for stillbirths, and I just thought I'd show you guys the different things that they make for mementos. They make very tiny gowns and hats. very tiny little stuffies that can go in the pictures as well. And then this image in the middle here is a cuddle cot. A cuddle cot is a cooling bassinet so that we can keep the baby in the room with the parents for as long as possible. It used to be that we could only keep them with the parents for 1 to 2 hours, and then we'd have to take them down to the morgue for a little while so they could get cold, and then bring them back if the parents wanted to see them again. But now with these cuddle cots, they can sit them in the bassinet and keep them in their room with them, so they can spend as much time as they want with their baby before going home. And again, we do give them as much time as they want. There's no limit to the time that they can have with their babies. It's a very tough process. They actually make cuddle cots that are smaller for smaller babies as well. Very tough to deal with. It's not all roses in labor and delivery. We do have to deal with some tough things and help our patients through that. And have to talk about too. So I'm glad I've recorded this lecture so that we don't have to do it with everybody. If this was very tough for you, please feel free to reach out to me. If you're comfortable, I'm happy to chat with you, but I also wanted to provide our Gateway Community College Counseling Services listed here. The website is there as well, and ways to contact them. They have counselors available on campus, in person and virtual as well. It's our lecture. I'll see you all in class.